Well, the key lessons learned from the IN.PACT DEEP trial are several, I think. Some of them presumptive and some of them I think are related to the trial design. To review, the IN.PACT DEEP trial looked at a drug-coated balloon for critical limb ischemia in the infrapopliteal vessels. The trial had patency and clinical outcomes as primary and secondary measures. The results of the trial were, I think, surprising to most people because the trial came on the heels of several single-center studies in Europe, in Italy and Germany primarily, which showed that there were remarkable and dramatic effects on patency and potentially on limb salvage by the use of drug-coated balloons for below-the-knee critical limb patients. In fact, the trial showed no difference in clinical outcomes between the two groups, between angioplasty and drug-coated balloon. And it also showed, interestingly, no material difference between patency rates. That is, late lumen loss was the same between the two groups. And that was adjudicated by two different core labs as a means of assuring that result. In addition, there was a potential trend toward a worse outcome in the drug-coated balloon group because they had more, or a trend toward more limb amputation. So that's the framework under which we talk about the IN.PACT DEEP trial, and I think there are several things we could suppose may have been problematic with the trial. First is that this balloon is made differently than the SFA balloon from the same sponsor, Medtronic, and the SFA balloon has been shown in the IN.PACT SFA trial to be extremely effective in that limb territory. It's made differently, it's coated in a different fashion, and it may be that the technical features of how the balloon is made are actually meaningful in this trial. Secondly, the issue around how the balloon is used wasn't prescribed by the trial. So the travel of the balloon through the vessel, how far down the bloodstream it had to go before it actually delivered drug is one that's is not clear. My point there is if you have a proximal sheath near the top of the common femoral artery versus one that's at the popliteal artery, you're going to have a very different potential drug delivery at the site of intervention. Third, it appears that, at least in some of the preliminary kind of anecdotal analyses, and this has not been borne out yet by any official analysis, that there may be anatomic issues related to the trend toward worse outcomes in the DCB group as regards amputation. What I mean by that is amputation is multifactorial. One of the things that may have happened is that there was no control for pedal runoff or integrity of the pedal vessels. And as a result, it might have been that some of these patients were, by luck or chance, distributed unevenly into a drug-coated balloon arm. And for that reason and others that we don't understand, the results may have been confounded. The other supposition, however, is that the balloon is actually injurious, that particulate matter that contains paclitaxel antiproliferative agents into a wounded limb may in fact be noxious. We don't know that, but these are some of the highlight caveats that might have helped us understand the IN.PACT DEEP trial and might help inform future trials. The last thing I would say is that the IN.PACT DEEP trial sought to assess actual stenosis severity by angiography, which is the gold standard. We all would acknowledge that. But in the infrapopliteal segment, it's very difficult to do with reliability because of shadow overlap with bony structures, misregistration on digital subtraction acquisitions, calcification of vessels, and so on. And so that there may be difficulty in assessing actual effect, especially late lumen loss, and patency binary stenosis in an environment where the actual angiogram is difficult to interpret. Having said that, it also may be important, it may be less important to nuance stenosis severity as it is to really determine whether the vessel is open or closed, which in critical limb ischemia is probably more important. So these are, again, endpoint and methodologic as well as technical issues that may help inform future trials.